Alright guys, so now we're going to talk about wound infections. So remember, wounds are going to be different than skin infections because with skin infections, the skin is intact and you have something either colonizing the skin, or what it's doing is it's actually getting past the skin using something like hair follicles. Now, with wounds, we're dealing with breaks in the skin and the mucous membranes. That means that our normal microbiota, as well as other microbes, are able to get places they would not normally go, and they contaminate the wound. This can lead to infection. Whether or not an infection occurs is actually going to depend on a few different things. What is the virulence of the microbes? How many bacteria end up in the wound? What is your immune system like? And the type of wound that you have. So you actually have different types of wounds. You have things like incisions. These are going to be produced by small knives, scalpels, small sharp objects. You have punctures. This is when you get penetrated by a sharp object. The difference between an incision and a puncture is an incision has length, not just depth. A puncture is deep, but it does not really have length or width. You have lacerations. This happens when tissue is torn and ripped. You have contusions. This is when you actually crush tissue. Contusions can be problematic because it actually causes anaerobic conditions within your body, and it allows anaerobic organisms to colonize in places where they couldn't because you normally have oxygen in those tissues. Abrasions occur because the epidermis is being scraped off. You have gunshot wounds. These are caused by bullets and other projectiles. Historically, they were also caused by things like crossbows, bows. Even sword wounds would fall under the category of the types of infections that you see with gunshots. You also have burns. These are going to be caused by heat, electricity, chemicals, radiation, or friction. Now, the thing with wounds is that they are exposing tissue that's normally protected, things like collagen, fibronectin, fibrinogen. And when you look at how a wound heals, you actually have connective tissue and capillaries reaching out and regrowing, and they're trying to fill the space created by the wound. As the wound shrinks, it's going to be converted to collagen, which helps form scar tissue, and then you have the skin or mucous membrane growing over the wound. Now, in some cases, you actually need debridement. This is when you remove dead, damaged, or infected tissue. In some cases, I'm going to be honest, removing it is really your only good option. And that includes not just removing damaged tissue, that could even mean amputation of hands, feet, arms, and legs, depending on what you're dealing with. Now, when you look at wound abscesses, this is when you have an abscess. So you have localized pus surrounded by inflamed tissue. So pus is going to be this thick yellowish fluid composed of leukocytes, tissue, and proteins. Abscesses actually form because of your body's defense systems. They can actually help localize an infection to a specific area, although bacterial cells can escape. And the thing is, abscesses can be difficult to treat. They have no blood vessels, and adjacent blood vessels are often blocked by blood clots. This means that there's not a lot of circulation, and that means that antimicrobial substances can't get to the infected site, and the presence of pus can actually impact how well those antibiotics work. When you look at microbes inside of abscesses, a lot of times they've stopped dividing. Again, antimicrobial medications don't work as well on bacteria that are not actively dividing. A lot of times with abscesses, they either need to burst, so they need to move upwards to the body surface and break, or they have to be surgically drained in order to get rid of them. Now, with anaerobic wounds, you see things like Clostridium tetani growing. Members of Clostridium tend to prefer anaerobic conditions when they grow in the human body. You see this in wounds that have extensive damage and they're contaminated with dirt, or you have these very deep punctures that are small in terms of wound size. You can also have infections that are polymicrobial, where you have multiple species living in association with each other, almost like a biofilm. But the thing is, the facultative anaerobes will use up the oxygen in that localized area that then produces anaerobic conditions for things like Clostridium to grow. Now, when you deal with infected wounds, they can have serious consequences. When wounds are infected, they often have delayed healing. You can have the formation of abscesses. You can have the spreading of bacteria or their toxins elsewhere. You also will find that surgical wounds will split if there's too much swelling, and that can allow the infection to spread, especially if there's a device. And if you're dealing with an artificial hip or an artificial knee that's been implanted, if it gets a bacterial infection on that item, you actually have to remove the device, heal the infection, and then do another surgery to implant a new sterile device. That is really, really hard on a patient. So first we're going to talk about staph wound infections. So remember, when you look at staph, it's commonly found as part of our microbiota, especially in our nostrils and in our skin. The two species included here are Staph aureus and Staph epidermidis. Now, when you look at staph, remember it's pyogenic, so it can actually cause the production of pus. Infections are characterized by inflammatory reactions. If the infection is large enough or it spreads to your blood or lymphatic system, you will have a fever. And you can actually have toxic shock syndrome resulting from strains that produce certain toxins. You have a high fever, muscle aches, life-threatening drops in blood pressure, and shock. Now, for the most part, we associate toxic shock syndrome with tampon use in women during their periods. However, you need to realize that toxic shock syndrome can occur in other situations. It causing infections in women using high absorbency tampons is actually considered a new technological emerging way that staph causes infections. So when you look at staph wounds infections, again, the causative agents are going to be Staph aureus and Staph epidermidis, and they are gram-positive cocci. They are facultative anaerobes. They will grow in clusters. They are very hardy. They survive well in the environment. They grow well on dry, salty skin. And you actually will use the coagulase test to distinguish Staph aureus from other types of staph. You're going to find that Staph epidermidis actually is a common cause of healthcare associated infections, and you're going to see that Staph aureus causes more serious wound infections. So with Staph aureus, remember it has a number of different virulence factors, and how bad the infection is going to depend on which factors it does and does not have. We do not produce a long-term immunity to staph. We tend to have intense inflammatory responses, so excessive pus is produced. And you can have other systemic complications occurring. So the bacteria can actually spread and form abscesses, and some strains are going to produce superantigens, which it just makes it problematic to deal with. Now, with Staph epidermidis, it's not especially virulent. As a rule, it can't invade healthy tissue, but it can cause minor abscesses around stitches, and it can adhere and colonize medical devices, so you have to be really careful about keeping medical implants sterile. They can also be associated with biofilms. So remember, when you're dealing with biofilms, antibacterials don't work very well. And if you have bacteria breaking free, they can then lead to things like endocarditis or abscesses and all sorts of other secondary complications because now they're in the bloodstream and the heart. Now, when you look at carriers of Staph aureus, they are at an increased risk for surgical wound infections. And how old you are, your health, if you're immune compromised, or you have an extensive period of time in the hospital before your surgery, can all be factors in terms of your risk of Staph aureus infections. When you look at Staph epidermidis, this is even more commonly found on our skin and in our noses than Staph aureus is. It is important to remember that MRSA, methicillin-resistant Staph aureus, is a serious problem. We also have VISA and VIRSA, so the vancomycin intermediate Staph aureus and vancomycin resistant Staph aureus. What really helps here is thorough cleaning of wounds to help reduce infections. What Well, how do we treat these? It's becoming harder because a lot of our antibiotics of last resort are no longer being useful. You really just try to isolate patients that have MRSA, VISA, and VIRSA so they don't give those strains to other patients. You try to keep wounds very, very clean so patients aren't at risk of getting staph infections. You might even have to do the strain testing to see what antibiotics work, what don't work. You might have to give them multiple antibiotics. It really comes down to each individual patient sometimes, if you have one of these nasty strains of staph. Now, we also have group A streptococcal flesh-eating disease. So Streptococcus pyogenes can commonly infect wounds. However, it's usually easy to treat because it is susceptible to penicillin. However, if you get a severe infection, it progresses rapidly. It'll spread into tissues and organs. You have pneumonia, you can have meningitis, puerperal fever, necrotizing fasciitis. This is when you have flesh-eating bacteria, and shock. When you have these symptoms, they occur very quickly. They're very serious. You're going to have severe pain at the wound site. You're going to have swelling and discoloration. You're going to have fever and confusion. If you don't treat the patient right then, they are going to go into shock and they're going to die very quickly. So the causative agent is Streptococcus pyogenes. It is a gram-positive, chain-forming, air-tolerant organism. It has a number of different virulence factors. The issue with this particular strain is that it has exotoxin A and B, so it causes toxic shock, and it has a protease that destroys tissue. It has all sorts of nasty enzymes. Think about what these enzymes are doing. They break down blood clots, they break down connections between cells, they break down DNA, they break down RBCs and neutrophils. Right? Does that not sound like, oh, let's just destroy everything? And certain strains do cause the streptococcal toxic shock syndrome. This is not very common in the United States, but it can happen. So less than 2% of deaths from strep pyogenes are due to necrotizing fasciitis. Typically, individuals that get that have some other risk factor: diabetes, cancer, AIDS. They've just had a surgery, an abortion, chickenpox. They abuse needle injection drugs. And the issue is that the toxin spreads so quickly, you need immediate surgery to remove the tissue and reduce pressure. Penicillin is useful if you do it early, but it's not effective if you have bacteria in necrotic tissue, and it's not effective against the toxins. Remember, you have to treat the bacteria and the toxin, not just the toxin. So a lot of times you have to remove the dead tissue to reduce pressure. Again, penicillin is useful if you get it early enough, but it doesn't do anything with the toxins. All right, let's pause here.